away from Miami. The eye department at the University of Miami is called Bascom Palmer Eye Institute. Some of you may be familiar with us. We have a very large eye hospital in Miami, which is one of the largest of its kinds in America. We have locations, other places in Dade County, plus Plantation in Broward, Palm Beach Gardens, and we're working on Abu Dhabi, but the COVID pandemic seemed to crash that. So I understand that most of you are interested in careers in medicine or in healthcare, which I think is terrific. Ophthalmology is one of the smaller fields in medicine and healthcare. There are just fewer of us than there are of internal medicine doctors and general surgeons and pediatricians. So this is an opportunity to learn about it. I'm very happy that I went into ophthalmology. I think of all the available specialties, it really is sort of the most fun, the most intellectually rewarding. And I've got about 45 minutes to go through some of this with you. So ordinarily, I would prefer to have this more back and forth, open-ended. It's hard to unmute everybody, but if you've got sort of a pressing question, maybe you could send it through the chat or either indicate it to Melanie or Maria, because if you're really having trouble with something, then it could be that everybody else is too. So we want to get that straightened out. But with that, let's get started. So very briefly, Bascom Palmer was one person. That was his name, Dr. Bascom Palmer. He was an ophthalmologist in Miami in the 1920s and 1930s and 1940s. And he was concerned that there wasn't any facility for the blind and visually handicapped in Miami. And when he died, he left his estate to what was then a brand new medical school, which was the University of Miami, which was the first medical school in Florida. And in gratitude, the university named the facility after him. So we're all here because of Dr. Palmer's generosity. Okay, so this is a federal government map. These numbers are a few years old, but it really hasn't changed. This is the prevalence rate, or the percentage of patients with either vision impairment or blindness for persons age 40 or older, broken out by states. So, some of the print's a little small, but basically the lighter colored states have less vision loss and blindness, and the darker colored states have the most vision loss and blindness. In Florida, it's really kind of on the dark end here, right? And we figure that's probably because of the elderly population. Most eye diseases are more common among older people. So some of the oldest states in America, average age of population, Florida, Maine, which is also sort of very high on the list, and not really a state, but Puerto Rico has some of the older populations. So the demographics of the United States indicate that the population on average is getting older and older year after year. And eye diseases are more common in older people year after year after year. So if you're interested in ophthalmology, we certainly need all the help we can get. And this is another way of looking at the same numbers, but when you break it out by race or ethnicity, right? Not a lot of people with blindness at younger age groups. And I know 40 to 49 doesn't sound young to most of the people on the call, but it sounds young to me, actually. But as you get older and older, it really doesn't matter, right? The amount of vision impairment and blindness goes up. So it's really the oldest that are most at risk for vision loss and blindness. So what ordinary people call an eye and what ophthalmologists call the eye may or may not be the same thing, right? What we refer to as the eye is probably what most people refer to as the eyeball, or sometimes we call it the globe, like a globe in your classroom, which is really just the round white part. That's the actual eye. Now the lids, the lashes, the bones, right? The muscles connecting the eye, the structures behind the eye in what we call the orbit, or what ordinary people call the eye sockets, right? Those are all in our territory. And again, a lot of times patients will call up and say, I've got a spot on my eye, when really what they mean is a spot on their eyelid or on their eyebrow, but we're pretty specific. And, you know, an eyeball is roughly the size of a grape, if you can picture that. Or another thing that might be in your pocket right now is a quarter. So if you took a quarter and turned that into a sphere rather than just a flat disc, that's pretty much the eye. But there's a lot going on in there, and for that one little small part of the body, there may be more going on there than in any comparable grape-sized part of the rest of the body, and that's sort of the fun of ophthalmology. And when you look at the eye, which is what we have here in the upper left, this is a left eye, and the reason you can tell it's a left eye, you can sort of tell by the eyebrow, right? And you can tell by this sort of fleshy pink part over here that you don't have on that side. And when you look at yourself in the mirror, there is a little fleshy pink part there. That's called the caruncle. But the white part is called the sclera. It's sort of the wall of the eye, the sclera. Overlying the sclera is a clear layer called the conjunctiva. When the conjunctiva becomes inflamed, either from infection or from other cause, we call that conjunctivitis or pink eye. Most people have known somebody who's had a pink eye for a conjunctivitis. There is a clear part in the center of the sclera. So there is no sclera when you get to that clear part. The clear part's called the cornea. So I know high school students don't necessarily wear watches anymore. That's sort of something that older people do. But for those of you that still wear a watch, and it's not a digital watch, but it's an actual watch with hands on it, it's sort of like the watch with the hands on it, that the glass part at the front of the watch is the cornea. And then there's a little tiny space, and then behind the space is the face of the watch where the numbers are. So the face of the watch in this case would be the iris, right, which goes around in here, and irises come in different colors, right? It's one of the few body parts that really changes color dramatically from one person to another person. Sometimes they're blue and sometimes they're green, but most people have one or another shade of brown iris. And in the center of the iris actually has a hole. The hole is the pupil. The pupil is what lets the light in. So the iris is full of muscles, and the iris muscles can either contract or relax to make the pupil bigger or smaller depending on the lighting conditions. So in bright light, the pupil tends to get smaller, it tends to constrict because less light is needed to get in. In dark light conditions, the pupil tends to get bigger, so it tends to dilate. If any of you have ever had an eye exam in an office, then your pupils may have been dilated with medication because it makes it easier for a physician to see inside the eye for all the structures that are deep inside. Immediately behind the iris, centered in the pupil, is the lens. This works exactly like a lens in a camera. It's what focuses the light. So just like a camera, there's a lens in front and there's film in the back, and the point of the lens is to focus the light onto the film. And in this case, we call the film the retina. And the retina absorbs the light and turns it into an electrical signal, which goes out the back of the eye, down the optic nerve, and that goes to the brain. And those are more or less the parts of the eye. Because this is in 3 dimensions, this is a space in here. And that space is filled with a jelly-like material that we call vitreous. And the vitreous doesn't do much, actually. You'll find that there's a surprising number of body parts that don't actually do much, right? The appendix, the tonsils, other than make trouble. So the vitreous is mostly important in older people when it starts to make trouble, like it creates floaters, which is why a lot of old people complain that they see floating spots in their vision. It really is in the eye, in the vitreous. This is a more detailed view of the eye, and this is probably more detailed than you really wanted to get into. But again, this is an eye that's pointing to the left of the screen. This is the front of the eye. This is the back of the eye. The cornea is the clear part, like the face of the watch. The iris and the pupil control how much light gets to the lens. The lens focuses the light through the vitreous onto the retina, right? And the retina catches the light and converts that signal to an electrochemical impulse like other nerves in the body, which then travels down the optic nerve into the brain, and the brain interprets the the images. And here's yet another view of the same thing. Here the eye is pointed in the opposite direction. So the front of the eye is towards the right. The back of the eye and the optic nerve are towards the left. What they really sort of focused in on here is this is a slide talking about one of the leading causes of permanent blindness in America, which is called glaucoma. You may or may not have heard of this disease or know somebody that suffers from glaucoma. It turns out that the eye has a pressure, sort of like a tire has a pressure. And like your tire, you'd like that pressure to be within a certain range. So you don't want it to be too small and you don't want it to be too big. You want that pressure to be sort of just about right. And glaucoma is a group of diseases where the pressure tends to be too high. And if it's too high for too long, eventually the optic nerve becomes damaged. And the optic nerve is a very, very important part of the eye because, again, the optic nerve is the connection from the eye, which captures the light, to the brain, which interprets the images. So anything that damages the optic nerve is bad for vision. So we know if the pressure is too high for too long, that you'll have damage to the optic nerve. So generally, patients with glaucoma are treated either with medicines or with laser treatments or with surgery to lower the pressure. And this is just sort of a bigger view from the side of the lens and the iris and the cornea. And this will become more important later when we go through a video of cataract surgery. So you want to try to keep these relationships in mind, right? The cornea is in front. It's like the watch glass. And the iris and pupil are just behind it, but there is a space in between it that's like the watch face. And behind that is where the lens sits. And I'm just trying to get the slide to advance. See, it happens to us too. There we go. So this is a drawing of what it looks like if you were to look into the eye, from the front of the eye towards the back. And this is the optic nerve like we talked about, right? And the optic nerve is very, very small for such an important structure. The optic nerve in most people is about 1.5 millimeters in diameter. About 1.5 millimeters in diameter. So if you have a sense of what a millimeter is, that's pretty small. An inch is about 25 millimeters. Or another way of thinking about this is your pinky fingernail. If you can look down at your pinky right now, your pinky fingernail is usually about 10 millimeters across. So the optic nerve is, between 1/10 and 1/5 that size, but that's really all the information. That is the connection from the eye to the brain. The retina is all of this around it. And the center of the retina has a very specific name, which is why we put it here. The name is macula. Right? Macula. I'm going to get into why it's called the macula. But the macula is the center part of the retina. And the macula is the central part of the retina that gives you the finest detail vision. And I'll try to advance the slide again. No, there it goes. So here's a photograph of an eye, right? So again, the lids, the lashes, but what we really think of the eye is the white part here, right? The ball, the globe. And the sclera is the white part, but then the cornea is the clear part. And this is kind of a dark photo, but I think you get the idea, especially when we move on to the next one. Right, so here's a blue-eyed patient, so it's easier to see the structures. So this is all iris. And the center of the iris we call the pupil. This white part here is a reflection from the flash from the camera that took the picture, so we won't worry too much about that. So the pupil's a space, the pupil's a hole. Right behind the space of the pupil is where the lens sits. And this is an eye with, with some issues, actually. This is not a normal, healthy eye. And you can see big red blood vessels on the conjunctiva, which could be for a lot of different reasons. There's a yellowish growth over here. This is surprisingly common. This is called a pingueculum. This is benign ultraviolet sun damage that you see in a lot of people, especially in places like Florida. This is a right eye. You can get the sense of that because the fleshy pink part, the caruncle, is over here. So this is the right eye. All right, this is a photograph of the inside of the eye. We tend to refer to this as the fundus. That's a funny word, F-U-N-D-U-S. Other parts of the body have a fundus too. Notably, the stomach has a fundus. It's really what we call, when we look down a hole to see inside of something and you hit bottom, we tend to call that the fundus. This is a right eye. The optic nerve is here. The retinal blood vessels are here. The macula is here, right? And it's worth talking about the blood vessels for a minute. We can take these photographs in a living eye. There are currently apps for your smartphone that if you get it just right, you can take a picture of your own fundus, a picture of your own retina. So these are the only arteries, veins, and nerves in the body that you can just look at in a living person, right? Anything else, if you want to see the arteries, veins, or nerves, you have to do some sort of a test. You have to do a CT scan or an MRI or something like that. There's no other way of looking. The inside of the eye, right? The eye is the only part of your body, other than maybe your fingernails, that's totally clear that you can see through it and look to see what's on the other side of it. And that's part of what makes ophthalmology so fun. So again, the optic nerve, 1.5 millimeters or so in thickness. There are arteries and there are veins. Can you tell which are which? And the answer is actually yes, you can, right? In this view you see here, the arteries are the thinner, pinker ones. This is an artery here. And the thicker, redder ones are the veins, right? Now, I know you guys have probably covered at least some of this, at least the juniors and seniors among you. Maybe the younger students haven't done it, but we know that one of the important differences between arteries and veins is that arteries have a muscular coat over them, right? The point of the artery is to take blood from the heart to the rest of the body, and the veins take the blood from the rest of the body back to the heart. So the outbound trip from the heart to the rest of the body requires muscle, requires energy to put the blood out there. And then it just sort of falls back along the veins. So the arteries are thicker because they have a muscular coat. But then when you look inside the eye, it doesn't really look that way. It really looks like the arteries are thinner and the veins are thicker. And how does one explain that? And this is something we go over with all the new medical students and all the ophthalmology residents. And you might as well hear it now. What you're seeing inside the eye is not the arteries and veins, not the arteries and veins. What you're seeing is actually the column of blood cells within the arteries and veins. That's the magnification you're seeing. That's the level of detail that you're seeing. So the column looks a little thinner in the arteries because the muscular coat's in the way. And that's why it looks a little paler, less red, and it looks a little thinner because the muscular coat is in the way. Arteries never cross arteries, veins never cross veins, and that's how you can tell where you are. But the level of detail you can get on an eye exam is sort of amazing. So then we're going to go back to the macula over here. The macula is the center of the retina. And we call it the macula because it's a Latin expression. It's short for macula lutea. For those of you that don't keep up with Latin, we'll go through why it's called that. Right, macula is really short for macula lutea. What does this mean? Interestingly, I gave a version of this talk, not as sophisticated, obviously, to the 4th grade class at Mason Classical Academy in Naples. This is maybe 8 or 9 years ago. And the 4th graders at Mason all are taught Latin, and they all knew this. So I know this is we have you all on mute, so if any of you know the Latin for macula lutea, you're not getting credit because I can't hear you. But I give this talk all the time, mostly to adults, mostly to older people, actually, who really should know better, and they never know it. And the only group I've ever given this talk to that knew what macula lutea was the 4th grade class at Mason Classical Academy. So you guys are probably too young for this, but there used to be a TV show called Are You Smarter Than a Fourth Grader, where they would take adults, right, on the game show and ask them questions that were on fourth grade school exams. You'd be surprised when people don't know. So macula lutea means yellow spots. But why would they call it that? It doesn't look yellow, right? If anything, the optic nerve looks yellow. The macula looks sort of reddish, right? Maybe in this one, maybe a little reddish brownish. But why would they call it a yellow spot? Well, the reason is the ability to look inside an eye is a very new thing from a historical point of view. It's maybe 150 years old, right, that we've had the ability to look in an eye with something called an ophthalmoscope. Before that, nobody knew what was inside an eye, and the only way to know what was inside the eye was to take a cadaver and to take somebody who had died and open the eye in an autopsy type specimen and cut it open and look at it. But it turns out that once you do that, it doesn't really look the same after death as it is in life. So this is the closest I could get you. This is a pathology specimen. This is a left eye, not a right eye, because the optic nerve is over here. But in death, the macula does sort of turn yellow. So this is an example, and you're going to get a lot of these, right, once you hit the healthcare profession, of us calling something a name that doesn't make sense anymore. That the name made sense 200 years ago when the name was given. And we're all just sort of stuck with the name. And this is an example of that. So macula, which means spot, which is short for yellow spot, which only applies to an eye in a person who's already died, but it doesn't look yellow in life. But that's the macula, very, very important part of the eye. So this is a newspaper cartoon from 1915 that I was able to find in a, oh, sorry, got backwards there. Let's see if I can go backwards there. Good. Say this is a 100-year-old newspaper cartoon back when people used to read newspapers. Newspapers had cartoons in them, right? And it says right here, look here, in the young, deterioration of the macula is rapid, right? So whether or not you think the cartoon is funny, and it didn't age well after 100 years, right? The people who put this cartoon in the newspaper 100 years ago thought that the average person in America who read the newspaper, probably most of which didn't graduate from high school, would understand what the macula was. So now this is more of a close-up, magnified view of the front of the eye. We had pictures like this before. The cornea up front, the iris over here, the lens back here, right? This is a view, which is a hard-to-get view that you need a special lens to see, of this little corner part in here, right? This is where the iris hits the edge of the cornea. This is the natural fluid drainage part of the eye. This is what controls the intraocular pressure. This is the level of detail that we look at eyes with. So the lens, again, very, very important part of the eye. This is a diagram of the lens, right? It's got different names for different parts. But really what I want to get you an idea of is there's an inner part and there's a shell on the outside, right? And we're looking at the lens from the side. But what I tell patients, and I have this conversation with them all the time, is that a human lens has the same shape and the same internal structure, and it's more or less the same size as an M&M. Okay, not a peanut M&M, but a regular chocolate M&M, if you can picture one of those. So it's about that size. It's sort of a disc. It's not really a sphere, but it is round and it's mostly flat. And then there's a shell on the outside and there's stuff in the middle, right? And the shell on the outside is called a capsule. And this is important because we're going to go through cataract surgery in just a few minutes. But the capsule on the outside is the candy shell and the stuff in the middle. And the stuff in the middle, there's actually two different types of stuff in the middle. There's the harder stuff more in the center. We call that the nucleus, which is kind of like the nucleus of an atom. It's the center hard part. And then around it is stuff that's very similar to nucleus, but it doesn't act like nucleus during surgery, so we call it cortex. So the candy shell on the outside is the capsule, and the stuff in the middle is the nucleus and the cortex, and it's a lot like an M&M, right? And here's what we're showing you. So this is a lens that's been taken out of an eye. So in an older person, the lens becomes cloudy. It's not clear anymore. This lens is almost turned brown, right? It's a pretty pretty dark lens. So as you can imagine, trying to see through a lens that's cloudy and brown isn't very helpful, right? That's what a cataract is. And in the old days of cataract surgery, the plan would be to remove the lens and replace it with a new lens. And they used to remove the lens in its entirety like this one. So you could pull it out, put it on a piece of paper, and take a picture of it. What's next to it is a ballpoint pen. So I'm trying to show you what the size of it is. So the tip of the ballpoint pen is on the left, and the removed cataract is on the right. So again, sort of the same size, shape, and internal consistency or configuration as a chocolate M&M, not a peanut M&M. Right, here's a way of looking at it from a different point of view. This is an eye that had an injury. You could tell it had an injury because the eye is red, right? The conjunctiva is what we call injected. There's sort of extra blood vessels there. The pupil doesn't really dilate properly. That's because the iris has become stuck to the capsule of the lens, so it didn't dilate properly. And we've got a cataract sort of in the center here. So it's really kind of a beautiful image. Right, all of this part of the lens is perfectly clear like it should be, but this part of the lens is cloudy. So whether the lens becomes cloudy due to age, or whether the lens becomes cloudy due to an injury or any other reason, we call it all a cataract. And the cataract, there is no medical treatment for a cataract. There's no medicine, there's no vitamin, nothing reverses a cataract. The only thing you can do with a cataract is to remove the cataract and replace it with a clear lens implants. And that, I think, is what we're leading up to in the next slide. If I can get it to advance. There it goes. So this is a surgical video, right? So this is a real eye, a real surgery. This is not my case. This is a cataract surgeon in our group named Dr. Alistair Gibbons. This is not sped up. This is real time. We're going to play it twice. It takes about 4 minutes, but I think it's worth seeing it twice so you can get a sense of what cataract surgery is. So cataract surgery is the most performed surgery of any type of surgery in any part of the body in America because it's not easy for the surgeon, but it's very easy for the patient. It's really very quick. There's not a lot of blood. You're only going to see a little bit of blood at the very end of the case. It's very, very successful. 99 out of every 100 people, more or less, that have the surgery come at it with better vision than when they went in. So this is why, if you talk to older people, lots and lots of them either had a cataract and are considering surgery, or already had cataract surgery and they're better. So here is Dr. Gibbons' cataract surgery. We're going to watch it, and I'm going to narrate it, and we're going to do it twice. So if something happens and you don't feel like you saw it, don't worry about it. We'll do it again. But it's not sped up. This is real time. So there's the eye. So it's just a little blade to make a little incision between the cornea and the iris. And a little bit of blood there, not a lot. That's just a little fluid to pump up the eye. And the next thing that goes in there, this is a material called viscoelastic. So it's a clear, thick material just to sort of hold everything in place. And this is the main incision in the eye. And it's maybe a 2 or 3 millimeter incision. And it's done as a 2-step incision like this because if you construct the incision properly, you won't need sutures when the case is over. The incision will close itself. So this is grabbing the front part of the M&M, the capsule, the shell at the part, and trying to open it up, right? So we're making a hole in the capsule in the front of the eye. And it really does just open like this. And he's trying to make a circle, which he's got. And then once you have a circle, it's a little bit of fluid that's going to be injected between the shell and the chocolate in the middle, if you want to think about it that way. So this is between the capsule and the nucleus and cortex of the lens. And you know you really have it separated nicely when you can spin it. So the technical surgery is called phacoemulsification. This here is sort of like a vacuum cleaner, but it doesn't just aspirate. It really grinds up the lens material. And you can see that it makes little grooves, right? It grinds it up and brings it in there, right? So the trick is to crack the lens in half, which he just did. And then it's going to be nice to get it into quarters. So you've got it cut in half. Now he's going to break it into 2 quarters there. And once you have it small like that, it'll grind up and go into the probe. And be sucked out of the eye in a million little pieces. Phacoemulsification. It uses ultrasound to grind up the lens particles. So that's half the lens. Here's the other half of the lens. Right, cracked it in half. The lens material, that's the nucleus, gets sucked up into the phaco probe. Sucked up into the phaco probe. So really what we've got here is just about an empty M&M shell with a hole cut in the front of it, but the whole rest of the shell is intact. And he's going to clean out some of the residual stuff that didn't make it out. That's that cortex that was on the slide. Right, just going to take out the residual cortex that's in there. This is all the stuff that didn't come out cleanly. So now really what you have is an empty capsule, right? We've made a hole in the front of the candy shell, taken out all the chocolate bits, and now you have an empty shell, which is just the right size and shape to put the lens implant in. You have to replace the implant, otherwise the eye won't see well. So the lens implant is very small, it's flexible, it's rolled up, almost like a taco, and the lens implant's going to go in, and it'll just unfold itself. Right? It'll flop itself open. Right, so the cataract is out. Here he's taking out that viscoelastic material, which is just sort of holding everything back, and we're going to help the lens sort of unfold. It's like a taco shell that sort of unfolds itself. And that's the implant. And one of the amazing things is you don't even really need to use sutures to close the wound. This is just a little fluid at the edge of the wounds. And when you inject the fluid into the side of the cornea, you get a little bit of swelling, which is why it turns white. And after a day or two, it's healed up and no stitches. A little bit of bleeding, like I told you. But really, very little blood for a surgery. So that was the entire cataract surgery, okay? And I know it's a lot to process, so we're just going to play it one more time for another 4 minutes. And this is the last slide I have for you. And after this, we can take questions. But that's that second incision. Right? The second incision actually gets made first, but it's really just to give you another way to reach inside the eye. But the main incision, that's the viscoelastic. That's just a thick stuff to hold everything in place. The main incision is a two-step incision. That's the first step. Here's the second step. And again, if you construct the wounds properly, it'll seal itself. You won't need any sutures. That's why people advertise no stitch cataract surgery. That's what they mean. This is opening the front part of the capsule or opening the front part of the candy shell of the M&M. Right, but the chocolate's still stuck to the remaining walls of the M&M. So you really want to get that chocolate dislodged. So that's what this little blast of fluid does here. You can see that the lens rotates a little bit. When the lens rotates, that usually means you've got it loose and then it'll grind up nicely with the phaco probe. So here's the phaco probe, which is the heart of the surgery. That's how you have to disassemble the lens and get it out of the eye, and it just grinds it up, vacuums it out. If you didn't have the grinding part, it would be too hard to just aspirate out. So this uses ultrasound waves to grind the cataract up into millions and millions of tiny microscopic pieces, and then they suck out nicely. Breaking the lens into quarters, because once you have it as a small quarter piece, you can usually just grind the whole thing up and take it out. Again, this is happening in real time. This isn't sped up. This is what a cataract operation really is. And this is why surgeons can do 20, 25, 30 surgeries a day sometimes. There are probably 20 million or more people around the world that are blind from cataracts. Most of those are people in the third world that live in some out-of-the-way place that you can't get a cataract surgeon to come to, and you can't get them to a cataract surgeon. So when you see what a straightforward surgery this is, that again works fine, probably 99 times out of 100, you appreciate what medicine and surgery can do for real people. It's just the last little bits of chocolate that have to get scraped out from the inside of the candy shell. Again, this is that cortex part. It's a little wispier. It doesn't always come out so easily, but there it all goes. A little more viscoelastic just to pump up the capsule to give a place for the lens implant to unfold into. Right, the lens implant is rolled up, almost like a taco shell, and you just stick it in there and it unfolds itself. There it goes. Taking out that viscoelastic material, because now the lens implant is there. We don't need it there anymore. Also sort of centering the lens. You like it nice and centered. And again, no sutures, just a little bit of fluid injected at the edges of the wounds. That's why it turns white temporarily. And the cornea becomes a little swollen there, and by the next day, the wound is pretty rock solid. As long as the patient doesn't rub their eye too hard, that'll seal forever and no stitches. So that's cataract surgery in the year 20. And let's see, that's all I got. I'm happy to take any questions. Thank you for inviting me.
All right, I'm gonna mute myself. So you, I believe you can unmute yourself. So if you wanna ask a question, go ahead. Or you can type it in the chat box. But I'll let—
Melanie, you might be muted. I can't hear you.
Oh, dang it. Am I muted?
I can hear you.
You can hear me?
I can hear you.
Yeah? Oh, okay.
Good.
Yeah. So wait, everyone else can hear me? Thumbs up if you can hear me.
How about that?
We can hear you.
What is your—
Oh, back on. All right. So yeah, so go ahead. You can unmute yourself to ask a question. Just make sure that when you are done asking your question that you mute yourself again, or else we're gonna have too many background noises going on.
Sorry, I don't know if you can hear me, but I can't hear anybody else. So
Oh.
we're having a technical issue here.
I'll just type in chat.
How about now?
Yeah. Can you—
Okay, now I got it. Now I can hear you. That's good.
Okay, perfect. All right. So
Sorry.
there's some questions in the chat box, and then we'll probably have some students ask some questions. So I'll
Okay,
just
so we
mute
can go
myself.
down the chat box. That's okay.
So
Share the, well, okay. What if the eye surgery fails? Right, so that's from Julie, I guess. You know, fails can be for a lot of different reasons, and some fails are recoverable with more surgery, and probably some fails aren't. So there's really nothing in medicine or surgery is 100%. Right, cataract surgery is probably as close as you can get to 100%, but you'll still meet people who, you know, whose vision was made worse by cataract surgery. Some of the things that can cause a cataract surgery to go badly would be an infection, right? Infections probably happen 1 in 1,000 times. Sometimes that can be treated with antibiotics, but usually it's a very bad thing to happen. For reasons that aren't totally understood, Some patients will develop something called a retinal detachment shortly after cataract surgery. And it's not clear why that is, because the surgery isn't really anywhere near the retina. It's in the front of the eye. The retina is in the back. But these are usually the biggest risks that we talk about. And then actually, probably the main reason why somebody would consider a cataract surgery to be a failure. Cataract surgery really works best when there's nothing else wrong with the eye, when the optic nerve is healthy, when the macula is healthy, when the retina is healthy. So if you have a cataract plus another disease in the eye, it could be that the cataract surgery was perfect, just the vision didn't get any better because of the other eye problems. So that's why it's very important to try to identify these problems before cataract surgery. Stephanie, right, what are the different types of lenses used for cataract surgery? So that's important, that's interesting, right? So I can see some of you are wearing glasses on the call. Some of you probably wear contact lenses, right? As you know, glasses come in different strengths, there's different powers. We measure the powers in what are called diopters, right? And diopters can either be positive or negative, depending on what you need. So most people are nearsighted, meaning they can see well up close when they're young, but they can't see far away without glasses. So those people have a negative number, right? They have a minus prescription, so -1, -2, -3. Alternatively, there are people that are what we call farsighted, meaning they're better off when they're young at distance than up close. And they usually have a positive prescription on their glasses, +1, +2, +3. So just like glass lenses come in diopters and powers, and contact lenses come in powers called diopters, the lens implants that go in come in diopters, and they actually come in quarter diopter steps. So, usually a lens implant that goes in an eye is in the range of +20, but it could be +20.25 or +19.75. Usually the numbers are in that range, and it matters. And we spend a lot of time trying to measure the eye to predict the best possible lens implants, because certainly a lot of patients don't want to have to wear glasses after cataract surgery, and we do our best, but that's another thing that's not 100%. What are the lenses made of? Do they last forever with no replacements? So the original lens implants are made out of a material called polymethyl methacrylate, which is acrylic. You might have things made out of acrylic in your house. The story behind acrylic as a lens implant, it's a famous story, because for many, many years, cataract surgery was simply removing the lens and closing the wound in the eye, which left the patients with no lens at all, which meant were very, very blurry, and you would need very strong glasses to see anything at all. But surgery was still done because that was better than nothing. But in World War II, in England, the little Spitfire planes, you've probably seen them on movies and on TV shows. They defended London during the Blitz. The canopies of the plane, it looks like glass, the cover of the plane that protects the pilot. It wasn't glass, it was plastic. It was called polymethyl methacrylate or things like that. It was made out of that material. And there were many, many cases in World War II of the canopy being hit by a bullet, and the canopy shattering, and little tiny pieces of the acrylic or the plastic type material ending up inside a pilot's eye. And if the injury wasn't too bad, then very often they would leave the piece of material in there, and the material could sit in there for years and years and years and never cause a problem, never cause an infection, never cause a bad reaction. So it was found sort of accidentally that this material could sit inside an eye for years and never cause a problem. So the original lens materials were made out of polymethyl methacrylate or acrylic. The problem with that stuff is that it's not flexible, it's not bendable. So you would have to make a big incision in the eye, big enough that you could slide the whole lens implant in. And then the next major advance in cataract surgery was the so-called flexible lens implant, which is a material like acrylic, but it's flexible and it rolls up and it can fit in a much smaller incision. So most of the lenses made now are made in a soft acrylic lens, or sometimes they're made out of silicone. How long do you go to school? Yeah, that's a good question, right? So if you want any medical specialty, right, generally speaking, 4 years of college, 4 years of medical school. Sometimes you can do a combined program in 7 or even 6 years, but I'm not sure I'd recommend that because you'd end up so much younger than all your classmates that at some point it becomes awkward. But 4 years of college, 4 years of medical school, then when you graduate medical school, you are a doctor, but you can't really do very much because you haven't really been taught the specifics of what you need to do every day, and that's when you specialize. So you have to do something called a residency after that. Depending on the specialty you want to go into, residency usually lasts between 3 years and about 6 years. Ophthalmology is 4 years. The first year after residency is sometimes called an internship. But for ophthalmology, it's 4 years of college, 4 years of medical school, 4 years of internship and residency. If you want subspecialty training after that, I became a retina specialist. That was another 2 years beyond that. So my first job was at age 31, and I never missed a year of school. It just took that long to get through everything. Have I performed surgery? I was never a cataract surgeon professionally. That's from Ida. I certainly did cataract surgery during my training. I wanted to be a retina specialist. Retina specialists do a different type of surgery. The main surgery we do is called a vitrectomy. We talked about that vitreous jelly, which is the gelatinous stuff that fills up most of the center of the eyeball. So if you picture a tennis ball or a basketball, the whole center of it is empty. It's air, but an eye doesn't have air. An eye has this jelly vitreous. And the vitreous doesn't do a whole lot. And actually, the vitreous tends to cause problems, mostly in older people. And one of the things the vitreous can do is collect blood. So patients with bad diabetes, if they get bad diabetes in the eye, we call that diabetic retinopathy. Sometimes they bleed into the vitreous. We call that a vitreous hemorrhage. If the hemorrhage doesn't go away, we remove the vitreous. That's called a vitrectomy. But the cataract surgery is done more frequently, and that's why I thought you'd want to see that. I think we went over the education and training. From Ava, what do you believe is in store for the future of ophthalmology? What would be the end goal of ophthalmology as a whole? Well, the end goal of ophthalmology as a whole is everybody would be able to see and nobody would be blind. And we get better and better every year, right? Again, cataract surgery is 99 out of 100 people get better with a 4-minute surgery. The big problems right now in the rest of the world is you can't get cataract surgery because people are poor and they live in places where there are no surgeons and they can't travel to where the surgeons are. But in the United States, the 3 leading causes of blindness are: one is a disease called macular degeneration, which mostly affects older people. So that macula, that yellow spot in the center, in older people, the macula either bleeds or it just sort of fades away with age. And sometimes we can treat that with medicine and sometimes we can't. But when you meet older people who can't see well, that's usually the disease, macular degeneration. Some of them we treat with injections of medication into the white of the eye, which sounds worse than it really is. But macular degeneration, the second leading cause of blindness in America today, is glaucoma, which we discussed, which is high pressure in the eye that over time damages the optic nerve, which can eventually be permanent. Once the optic nerve is gone, it doesn't come back. We don't have a replacement. The scary part about glaucoma is that glaucoma early on doesn't have any symptoms. So glaucoma vision loss tends to come from the edges towards the center. So by the time you realize you're losing vision from glaucoma, it's already too late. So when you see eye doctors go through screenings, and I've done at least 2 screenings in Immokalee myself with the Lions Club, we're usually looking for glaucoma. That's the disease we're usually looking for. And the third leading cause of blindness in America is diabetes. So I think until you get rid of diabetes, you're not going to get rid of diabetic vision loss. Right? And getting rid of diabetes is a big thing to ask. All right, so it looks like Litzy gets the last question. How expensive is cataract surgery, and does it hurt once the surgery is done? Well, you know, most people who need cataract surgery are elderly, right? And most elderly patients have Medicare, so it doesn't really cost them much of anything. But I think the Medicare rate for a standard cataract surgery is, I'd have to check this, but it's in the range of maybe $700. So that's sort of what it costs, but there are cheaper ways of doing it. There are places in the third world that use less expensive equipment, use different types of ways of doing this. And I think you can get the cost much below $100, maybe even below $50. And really their outcomes, especially in places like India where they do a lot of this, are really very good. So you wonder how much of the high-tech equipment that we use is really necessary when you see what goes on in other parts of the world. Does it hurt when the surgery is done? Most patients don't have a lot of pain. It can hurt for a day or so, just sort of sore because you had work done on the eye, but usually a lot of pain is a sign that there's something terribly wrong, and those are the people that, you know, might have those problems, that might have worsening surgery. All right, I think it's 1 o'clock, and I'm getting messages that it's time to wrap up. Any of you are welcome to come visit us. We're on 41 in Naples. Rachel Christopher and Amy Lane are on this call now, and Melanie and I'm sorry, the lady from the Immokalee Foundation, I can't remember your name, definitely can get in touch with any of us, and we'd be happy to host tours and do more programs with you. But thank you very much.
There's a fly in my face. Awesome. Thank you so much. That was crazy. I didn't know there was so much that goes into being an ophthalmologist. But thank you for taking the time to come to speak to our students virtually. And thank you, students, for participating. So I'll save this recording in case you want to watch another cataract surgery. But I'll go ahead and just end the meeting. But if you do have any questions, just make sure that you can always reach out to Maria and I, and we can send those questions out. So thank you.
Thank you.
So much.